Assalamu alaikum. This is the second part of endocrine emergencies lecture. In the previous lecture, we discussed the diabetic emergencies. And in this lecture, we'll try to select some important non-diabetic endocrine emergencies to discuss each of them briefly. The emergencies that we will discuss today include thyroid emergencies, including myxedema, coma, and thyroid storm, adrenal emergencies in form of adrenal crisis, and calcium emergencies, both hypo and hypercalcemia. So if we start with myxedema, coma, we all know the hypothyroidism, but when hypothyroidism becomes a myxedema, coma, there is no clear definition based on biochemical level or on some scoring system. Myxedema, coma literally means a loss of consciousness in patient with hypothyroidism. It's a form of severe hypothyroidism. When patients with hypothyroidism develop impaired sensorium, that is impaired consciousness, this is myxedema, coma. And it typically occurs in patients who are undiagnosed or untreated hypothyroidism. Because if the patient is on L-thyroxine replacement therapy, it will be extremely rare for him or her to develop myxedema, coma. So it typically occurs in patients who are not known to have hypothyroidism or who are not taking their treatment for hypothyroidism. And usually there is some precipitant cause, which is common to almost all endocrine emergencies. Some systemic illness that precipitate the emergency. And these include infections, whether upper respiratory, urinary, or otherwise, cerebrovascular accident, stroke, or myocardial infarction, heart failure, certain drugs, particularly narcotics and sedatives, hemorrhage, loss of blood, severe hemorrhage, trauma, all these can precipitate myxedema, coma in patients with hypothyroidism. Now the clinical feature, there are two cardinal features that are usually present in most patients, if not all, of myxedema, coma. Unconsciousness, that's loss of consciousness, sometimes just an impairment in sensorium, impairment in consciousness, and hypothermia. And we find other features, clinical features, signs and symptoms of hypothyroidism, the usual signs and symptoms of hypothyroidism, like sinus bradycardia, numb-beating edema, cold intolerance, weight gain, hoarseness, voice, loss of hair in outer one-third of eyebrow, delayed relaxation of reflexes. All these are features of hypothyroidism that either result from decrease in the basal metabolic rate or from the deposition of glycosaminoglycans in interstitial tissues. Now, if you have patient with signs and symptoms of hypothyroidism and you find on top of them hypothermia and decreased level of consciousness, that is myxedema, coma. How we diagnose myxedema, coma? The diagnosis is mainly clinical. And there are laboratory features that confirm or suggest the presence of myxedema, coma. But we don't rely on lab features in order to start our therapy. So we can make the diagnosis just based on the clinical features without waiting for laboratory confirmation. But the presence of high TSH and low free T4 can confirm the presence of myxedema, coma in patients with signs and symptoms suggestive of the disease. Other features, if we do an arterial blood gas, we will find hypoxia and hypercapnia, and both result from the hypoventilation due to respiratory muscle weakness. If we do CBC, we may find anemia. Anemia is typically the anemia of chronic disease, that's the chronic normocytic anemia. but we know that in up to 10% of patients with hypothyroidism, there is an associated pernicious anemia in which the picture of the anemia will be megaloblastic. We might find hyponatremia, and hyponatremia is typical of severe hypothyroidism, and it usually results from increase in antidiuretic hormone which lead to extracellular volume expansion. We will find also hypercholesterolemia, sometimes hypertriglyceridemia, because the metabolic rate of the rate of metabolism of cholesterol and lipids is decreased. The lactate dehydrogenase and the creatine kinase enzymes are typically increased in hypothyroidism. CSF pressure and protein content are higher, because sometimes when patients presented with decreased level of consciousness, to rule out CNS infection, they might undergo lumbar puncture to evaluate their CSF. But this is not required in usual evaluation of patients with myxedema coma. But presence of these features suggests the disease in patient who is presenting with the neurological symptoms. How do we manage myxedema coma? It's a medical emergency, and as we have said, we shouldn't wait for biochemical confirmation. We should start therapy immediately. And patients, because they are presenting with neurological and respiratory depression, they have to be supported, particularly regarding their airway and respiration. They should be admitted to intensive care unit, because most of them will need mechanical ventilatory support. This is the most important part of therapy because it's life-saving. And we should start thyroid hormone replacement as soon as possible. The preferable route is parenteral. But in case we cannot find parenteral thyroid hormones, we can give them orally through a nasogastric tube. And usually we give a larger dose than the usual replacement dose, which ranges from 200 to 600 micrograms. There is no consensus on the optimal dose, so we can use any dose of this range. And then we will start a maintenance of at least 50 to 100 micrograms daily. And we should treat the hypothermia, and usually with passive method like blankets, or by increasing the room temperature gradually. So these are the three major components of management of myxedema coma. We should support the respiration, we should replace thyroid hormones, and we should treat the hypothermia. And there is one sometimes controversial part of the therapy, but in some cases it's life-saving, which is giving the hydrocortisone from 50 to 100 milligrams every 6 to 8 hours during the first days of management. And the rationale behind using hydrocortisone, number one, that this might be a secondary hypothyroidism. And secondary hypothyroidism is a result of pituitary disease. And it's uncommon to have it isolated. It's usually part of hypopituitarism or panhypopituitarism. So we should suspect there is also a secondary adrenal insufficiency. So we have to give hydrocortisone to avoid relative adrenal insufficiency that will be exacerbated. Because when we give thyroid hormone, when we give thyroxine, and there is an pre-existing adrenal insufficiency that's compensated, when we give L-thyroxine and increase the basal metabolic rate, the patient will develop an adrenal crisis unless we support him or her with steroids. This is number one, that we are suspecting that with myxedema coma, with the central hypothyroidism, there is an associated secondary adrenal insufficiency because both result from pituitary disease. The second thing that if this is a primary hypothyroidism, not secondary hypothyroidism, there are two things that may be present. Number one, there may be a coexisting primary adrenal insufficiency because the most common cause of primary hypothyroidism is autoimmune thyroid disease. And there is an association between autoimmune thyroid disease and Addison disease. And the patient might have an underlying adrenal insufficiency, which is again compensated, but when we give L-thyroxine, that will result in overt adrenal insufficiency. So to protect the patient, it's better to give hydrocortisone. And the second thing, that the patient might have normal adrenal function, but especially in elderly or those who have what we call weak adrenal reserve, if we give large doses of L-thyroxine at once to treat myxedema coma, a relative adrenal insufficiency will occur. So it's preferable to give hydrocortisone in almost all patients with myxedema coma until we exclude coexisting adrenal insufficiency. So this is about myxedema coma, the first emergency that we will discuss today. The second one is the opposite, which is thyrotoxic crisis, or what we call thyroid storm. Now, it's very rare, and like myxedema coma, which is a severe hypothyroidism, thyrotoxic crisis is a severe thyrotoxicosis. Again, there is no cutoff point or certain scoring system that will say this is a thyrotoxic crisis, not just a simple thyrotoxicosis. We will see from the signs and symptoms when we think that this is a thyrotoxic crisis rather than thyrotoxicosis. But again, there is precipitating factors, and they are some are similar to an endocrine emergencies like surgery and trauma, right? Any acute illness, but they typically occur from withdrawal or non-compliance with anti-thyroid medication. This is the most common precipitant we see in clinical practice for thyrotoxic crisis. Radioactive iodine therapy is also known to precipitate thyrotoxic crisis because it will distract the thyroid gland, and there will be a release of large amount of thyroid hormones from the overactive gland. This is why patients who are given radioactive iodine therapy for thyrotoxicosis are usually covered immediately after the procedure with antithyroid hormones. Aspirin overdose, we know that aspirin can displace the thyroid hormones from their binding proteins, making the free fraction more available to act. If the patient takes thyroid hormone overdose, diabetic ketoacidosis is also reported to precipitate thyrotoxic crisis in patients who have thyrotoxicosis because there is a common association between patients with type 1 diabetes and thyroid disease. And lastly, vigorous palpation of the enlarged thyroid classically also is thought to precipitate thyrotoxic crisis. But usually, what we see in life, the first two are the most common precipitant of thyrotoxic crisis. Clinical features: when this is a thyrotoxic crisis, not simple thyrotoxicosis, there are cardinal features, including the hyperthermia, tachycardia, severe tachycardia out of proportion to the fever, meaning that the tachycardia is not just a response to the fever, and if there is GIT symptoms, nausea, vomiting, and diarrhea, sometimes abdominal pain, if they occur, that indicate that the patient who has thyrotoxicosis, or sometimes not known to have thyrotoxicosis, is in thyrotoxic crisis or impending thyrotoxic crisis. And we have the neurological features that they are, if present, this is definitely thyrotoxic crisis, including the agitation, the emotional lability, the confusion, sometimes psychological disturbances, and even coma, periodic paralysis, stroke, and even epilepsy may also occur. In patient with in elderly patient, we have something called apathetic thyrotoxicosis, that these dramatic features are not clear. The patient might not have hyperthermia, might not have neurological symptoms. He's just apathetic and showing no clear features of irritability or agitation. This is common in elderly. Again, the diagnosis depends on clinical features, and to confirm it, we should show high levels of T3 and T4. And there are other features that can accompany thyrotoxic crisis, and they are suggestive of the condition, including mild hyperglycemia, but later, if the condition continues without the treatment, there will be exhaustion of glucose stores in the body and hypoglycemia. There is high the cellular enzymes are high, including the lactate dehydrogenase, AST, ALT, and alkaline phosphatase. In some patients, there is also hypercalcemia. Now, how we manage thyrotoxic crisis? We have three lines of targeting the increase in the thyroid hormones in the blood. Number one, we should reduce the production of the thyroid hormones from the thyroid. We should block the effect of the circulating thyroid hormones in the body, and we should treat any systemic decompensation that occur due to thyroid hormones. So to reduce the production of thyroid hormones from the body, we use antithyroid drugs, thionamides like propylthiouracil or methimazole. We prefer propylthiouracil because it can also block the peripheral conversion of T4 to T3. But if we don't have propylthiouracil, we can use methimazole or carbimazole instead. The problem with thyroid hormones is that they will take some time to reduce the production of the T3 and T4. So we might give inorganic iodine in form of low-gas solution or in form of radiological contrast, the oral contrast that are used in radiology, because these products contain iodine that or iodide sometimes to block the release of already sensitized hormones. So they can stop they can affect the levels of thyroid hormones within hours. In contrast to the antithyroid drugs, which take sometimes days to exert their effects. And we might use other drugs that prevent the action of the thyroid hormones in the periphery, or prevent the conversion of T4 to T3 in the periphery, including propranolol and steroids. So, if we are faced with patient with thyrotoxic crisis or severe thyrotoxicosis, number one, we will give antithyroid drugs and we give them in the usual dose. For example, if we use carbimazole, we use from 40 to 60 milligrams a day. We give any form of inorganic iodine. Local solution is preferred because we know the concentration of it. If it's not available, we will use any oral contrast that is available in the radiology department, but we have to look for the dose, the proper dose. And we give steroids, usually any form of steroid. We prefer to use dexamethasone or hydrocortisone because we can give them parenterally. We give a beta blocker, preferably propranolol. If there is a contraindication to beta blockers because the patient has COPD or asthmatic or on examination we found some wheeze, we may give calcium channel blockers. The non-dihydropyridine calcium channel blockers like diltiazem or verapamil. And the third line of treatment is to treat any systemic decompensation that resulted from the severe thyrotoxicosis. If the patient is volume depleted, we will give him fluid. If he is hyperthermic, we will use antibiotic in form of paracetamol. You should avoid non-steroidal anti-inflammatory drugs. Cooling blankets and ice packs are also can be used. And if there is heart failure, we should treat heart failure. And we should treat the precipitating illness if it's present. So this is about the second thyroid emergency, which is the thyrotoxic crisis. Now moving to the, I cannot move the slides now. Okay. Moving to the adrenal crisis. Now, we all know adrenal insufficiency. Here I'm not talking about adrenal insufficiency as a disease, but I will talk about the emergency that occurs in patients with adrenal insufficiency. Adrenal insufficiency, when we say adrenal insufficiency, we usually mean the chronic adrenal insufficiency. We know that adrenal insufficiency or adrenal cortical insufficiency has two forms. Primary, that results from the disease of adrenal gland itself, or secondary, that results from a pituitary disease. Now, when we say adrenal crisis, we mean an acute adrenal insufficiency, which is not the usual form that we see. It's only an emergency that occurs on top, usually on top of a chronic adrenal insufficiency. And 15% of patients with chronic adrenal insufficiency, which we call the Addison's disease, usually die from adrenal crisis, usually die from an acute adrenal insufficiency. Like any endocrine emergency, as we have said, there is usually precipitating factors for the emergency to occur. The patients usually having a chronic adrenal insufficiency, and then some precipitating factors superimpose and produce the acute adrenal failure. Like DKA, acute adrenal crisis could be the first presentation in a diagnosed patient with chronic adrenal insufficiency, because the symptoms and the signs are usually asymptomatic, are usually non-specific. They are not picked up by the treating doctors or the clinician who see the patient. The patient develops non-specific symptoms of fatigue, nausea, sometimes vomiting and abdominal pain, and he's treated for these non-specific symptoms for some other illness, and at some point he will develop an acute adrenal crisis or an adrenal crisis. And sometimes the patient was untreated. I remember the last patient I saw with adrenal crisis, the patient with known adrenal insufficiency, but she was still in this cycle of investigation. They are still waiting for a result of synecdoche test, and at this point she developed an adrenal crisis because she is known to have or suspected to have chronic adrenal insufficiency, but she is not on any treatment. And adrenal crisis can occur in patients with no chronic adrenal insufficiency if some precipitant occur. The most common precipitant is acute gastrointestinal illnesses. Any acute gastrointestinal illness is known to precipitate adrenal insufficiency, mainly because it will impair the absorption of oral steroid. Because the patient is known to have adrenal failure, she or he is taking oral steroids to replace his endogenous steroids, but if he develops an gastrointestinal illness, the absorption will be impaired and the patient might develop adrenal crisis. Any acute febrile illness, any infectious illness that the patient gets, acute respiratory tract, upper respiratory tract infection, urinary tract infection, can precipitate the crisis. Abrupt withdrawal of steroids can also precipitate adrenal crisis. And I remember that one patient developed adrenal crisis because nobody told her that she has to take the steroids for life. When she was diagnosed with adrenal insufficiency, she was prescribed steroids for 2 months to come and follow the endocrine clinic again. But she was not aware that she should take them for life. So after the 2 months passed, she didn't come to her appointment, but she stopped the treatment, thinking that this is just a course of therapy. So any abrupt withdrawal of steroid can precipitate the adrenal crisis. And any procedure that the patient undergo, surgery, dental work, upper or lower endoscopy, gastrointestinal endoscopy, I mean, labor, if we don't cover the patient with extra doses of steroid, because these are stressful conditions that need extra doses of steroid. In normal people, the adrenal gland will produce an extra amount of steroids to cover these stressful conditions. But in patient with adrenal insufficiency, he or she is relying on exogenous steroids. So whenever he is exposed to this procedure, we should cover him with extra doses of steroids. The clinical features, as we have said, they are non-specific. Anorexia, fatigability, vomiting, abdominal pain, dizziness on standing, that is indicative of orthostatic hypotension. And the signs, the most important feature of adrenal insufficiency is hypotension or even shock. This is what should alert us to the presence of adrenal crisis in patients with known or sometimes unknown adrenal disease. The low blood pressure or the presence of shock is a typical feature present in almost all patients with adrenal crisis. The other sign that we might see is the hyperpigmentation of the skin and mucous membrane, which is seen only in primary adrenal insufficiency, not in secondary adrenal insufficiency. It's the result of very high levels of ACTH. But sometimes we might not see hyperpigmentation. We might see vitiligo, for example, because it's associated with primary adrenal insufficiency as an autoimmune disease. The diagnosis of adrenal crisis is clinical. If a patient is known to have adrenal disease and present with these signs and symptoms, we should diagnose him or her as having adrenal crisis, and we should treat immediately. There is no biochemical confirmation of the low steroid levels, for example, in the blood, or we don't need to repeat the investigation that we did at the time of the diagnosis of the disease. Whenever the patient presents with these symptoms, we should diagnose him or her with adrenal crisis. We should order other more important investigations like plasma glucose. We know that hypoglycemia is common. the sodium and potassium, we know that usually there is hyponatremia and hyperkalemia, and we should also assess his renal function. But if this is the first presentation, if we think that this patient is having a renal crisis, but he is not known to have chronic adrenal insufficiency, at that time, before starting treatment, we should quickly withdraw blood sample to measure ACTH and cortisol. This is only if the patient is not known to have adrenal insufficiency, but in patient with known adrenal insufficiency, there is no need to repeat this investigation. We should start treatment immediately. In both cases, we should start treatment immediately without waiting for the result of the investigation. But in patient with no prior history of adrenal insufficiency, we may add to the usual investigation, we may add the biochemical tests for adrenal insufficiency. The management, we should give parenteral steroids immediately, and usually in form of hydrocortisone 100 milligram every 6 hours. We should rehydrate the patient with fluid, preferably with normal saline, that is the 0.9% sodium chloride. And if there is hypoglycemia, we give dextrose. If there is any precipitant that we can treat, we should treat. Now, these are the major lines of therapy. The most important is to start hydrocortisone as soon as possible. And the treating doctor should give the hydrocortisone himself or herself, not just writing it in the note, waiting for the nurse to prepare it to give it to the patient, because this is life-saving and should be given even without prior writing in the notes or in the treatment chart. And once the patient is adequately hydrated, once the precipitating cause is treated, we can convert patient to oral hydrocortisone. Now, if the patient is known to have adrenal insufficiency before, we usually convert him to double his doses. For example, if he was taking 20 milligrams of hydrocortisone daily, after treating his precipitating cause, after rehydrating him, we can stop the intravenous hydrocortisone and start him on 40 milligram hydrocortisone for 2-3 days, orally I mean, and then he will come back to his usual dose. If this is the first, this is the adrenal crisis occurring patient who is not known to have adrenal insufficiency, we may give him a usual replacement dose, 20 milligram, because we know that the cause of adrenal insufficiency that he is taking for treatment. So it's enough to give him the usual replacement dose, that's from 20 to 30 milligram. And we should always educate the patient on sick day rules, similar to what we give the patient with type 1 diabetes. When they get sick, we educate him about not stopping insulin, about increasing their dose. Similarly, any patient who is recovering from adrenal crisis, we should educate him again if education is, sometimes education is not given before to him or her about what we call sick day rules. That is, he should double his steroid dose during any illness. If he is taking 15, for example, milligram of hydrocortisone orally, if he gets any illness, any febrile illness, he should double it to 30 milligram. If he is vomiting or unable to take orally, he should contact his doctor, because we might need to convert him to parenteral steroid until the vomiting stops. Otherwise, he will develop a renal crisis. And we should tell the patient to inform his doctor if he goes to any doctor for any procedure, for any intervention, he should inform the doctor about his condition. And the problem that the patient might not know that he has adrenal insufficiency by name. So usually, sometimes we give the patient special cars or special something to know that this patient has an adrenal insufficiency in case of emergency. If the patient doesn't know or cannot tell that he has adrenal insufficiency, but this is important not to precipitate adrenal crisis because of a medical procedure. So this is about the adrenal crisis. So moving toward the last two emergencies, that they are the calcium emergencies, the hypocalcemia and hypercalcemia. First, with hypocalcemia. Again, I'm not in this lecture. I'm not talking about hypocalcemia in general, because most cases of hypocalcemia that we see are not emergency. I will discuss when hypocalcemia is an emergency, and this occurs in two situations: when there is significant symptoms of hypocalcemia, or if the serum calcium is less than 7.5. Because when there is symptoms and serum calcium is low, there is risk of systemic complications due to hypocalcemia. What causes hypocalcemia? In general, there are causes due to parathyroid hormone deficiency, which is parathyroid-related hypocalcemia, including post-surgical hypoparathyroidism. When a patient undergoes thyroid surgery or parathyroid surgery, he is at risk of developing post-operative hypoparathyroidism, and that will result in hypocalcemia. This is the most common cause of hypocalcemia as an emergency that we see. Or sometimes we have congenital or inherited hypoparathyroidism or pseudo-hypoparathyroidism, which is an end-organ resistance to the actions of parathyroid hormone. These are three conditions in which there is deficiency of parathyroid hormone, or the parathyroid hormone is not acting properly, and that will result in hypocalcemia. Or sometimes the hypocalcemia is the result from vitamin D deficiency, either the 25-hydroxy vitamin D deficiency, which is usually occur in this is a common, but it rarely causes severe hypocalcemia. It occurs due to inadequate sun exposure or poor nutritional status. And we have the 125 dihydroxy vitamin D deficiency. This is the active form of vitamin D, which is typically seen in renal failure. And this is again a very important and common cause of severe hypocalcemia in clinical practice. Most of cases of emergency hypocalcemia, severe hypocalcemia we see are either due to post-surgical hypoparathyroidism, which is number one cause, and due to renal disease, renal failure. The others are very rarely can cause severe hypocalcemia. The clinical features of hypocalcemia include numbness or tingling, typically in fingers, toes, or around the mouth, muscle cramps, usually in legs and feet, and sometimes they progress into spasms in form of carbopedal spasm, in form of laryngospasm, the patient comes with stridor sometimes, or bronchospasms. And there are central nervous system abnormalities in form of irritability, impaired intellectual activity, personality disturbances, and even seizures. So presence of these symptoms indicate that the hypocalcemia is an emergency and need urgent treatment. Sometimes we don't see, sometimes the hypocalcemia is severe enough that the patient presents with tetany, that he has carbopedal spasm that are aberrant without any we don't need us to elicit them. But sometimes we need to show that there is an evidence of latent tetany. And this is typically done by what we call Trozier sign. Trozier sign, we use the cuff of sphygmomanometer and we elevate the pressure to around 20 millimeters mercury above the systolic blood pressure and keep it there for at least 3 minutes. The patient will develop what we call carbopedal spasm because there will be a decrease in blood supply to the muscles and nerves, and because the patient already has hypocalcemia, so within 3 minutes the tissue calcium level will drop to marked degree and the spasm will occur. The spasm will be in form of a flexion of the wrist and metacarbophalangeal joint and extension of interphalangeal joint with some adduction of the fingers. Now this is one of the signs what we call of latent tetany. Can be very painful. Now if we do it if you are still not sure about whether or not the patient is having hypocalcemia. We are still waiting biochemical confirmation, but if we have already confirmed that the patient has hypocalcemia by lab results, we don't need to show this. The other sign is called Chvostek sign, in which we tap over the facial nerve, and there will be twitching of the facial muscles on the same side. Now this can occur even in normal subject, up to 10 to 15% of normal subject that might occur, but it's very typical of patients with latent tetany. So this is another sign to demonstrate that the patient has latent tetany. We might do these signs if we are still waiting for calcium, or if we are not sure that the calcium result in front of us is true or not. We want to do more confirmation. But remember, these are not sensitive signs. They are not present in all patients. Their absence doesn't confirm the absence of hypocalcemia. Now, how we investigate hypocalcemia? If you have a low serum calcium from the lab, you have to correct it for the level of the patient's albumin, because we know that this is the total calcium and including the fraction that is bound to albumin. If the albumin is low, the calcium level will be low, but the ionized calcium is normal. So we have to correct the calcium for the level of the albumin, and we use this equation that we will subtract patient's albumin from 4.5, which is the normal level of albumin, multiply it by a factor which is 0.8, and the resulting number we will add it to the serum calcium of the patient, and this will make the corrected calcium. If the corrected calcium is within the normal range, and we know the normal range is usually from 8.5 to 10.5 milligrams per deciliter, that means that the lab result which showed hypocalcemia is only a measured serum calcium. It's not the corrected serum calcium. We have to do the phosphate because we know for establishing the diagnosis, the phosphate might help us. We usually do the magnesium, particularly if the hypocalcemia is resistant to treatment, because we might need to correct magnesium for proper correction of calcium. We do electrolytes and creatinine. We know that renal disease is one of the important causes of hypocalcemia. Again, alkaline phosphatase and assessment of the acid-base status might help us in establishing the cause. Parathyroid hormone also, and 25-hydroxyvitamin D, because we know that hypocalcemia is either due to deficiency of parathyroid hormone or deficiency of vitamin D. There are ECG changes which are suggestive of hypocalcemia, including the prolonged QT interval, prolonged QRS, the QRS and ST signal changes, which might mimic even the changes of acute myocardial infarction. Treatment. As we have said that if the hypocalcemia is an emergency, and we know that we consider hypocalcemia as an emergency if it's symptomatic or the serum calcium is less than 7.5. In this case, we need to admit the patient to the hospital. We need to replace the calcium parenterally in form of intravenous calcium, of course. There will be no place for oral calcium replacement as an outpatient. And we prefer to give calcium as intravenous calcium gluconate because other calcium preparations are irritant to the veins. For example, calcium chloride is very irritant. If we have to give it, we should give it by central venous line. The calcium gluconate is the most suitable preparation. And the dose usually depends on the symptoms and calcium levels. And we have to add one alpha-calcidiol, which is the active form of vitamin D, in patients with post-operative hypocalcemia, because we know that the main cause of hypocalcemia is parathyroid hormone deficiency. That means that there is no room for activation of vitamin D. So we have to bypass the system by giving the active vitamin D. This is also true for patients with renal disease. In these two causes of severe hypocalcemia, we have to give active vitamin D, that's one alpha-calcidol, with the calcium. Otherwise, the correction will be very slow, or sometimes we cannot get calcium to the normal level. And from the day we start intravenous calcium, we should start the oral calcium at the same time, because we have to establish the patient on the maintenance treatment to prevent the persistence of hypocalcemia or the recurrence of hypocalcemia. This is about hypocalcemia. Moving to the last emergency of the day, which is hypercalcemia. This is just to remind you that serum calcium level by most labs is something between 8.5 to 10.5. And we consider hypercalcemia as an emergency, again if it's symptomatic like hypocalcemia, or it's severe that serum calcium is more than 14. This is the level at which even if the patient is asymptomatic, we should treat it as an emergency. For the levels less than 14, we have to judge it by patient. Usually we are not afraid of calcium which is less than 12. Between 12 and 14, we should assess the patient condition accordingly. But above 14, definitely we should treat it as an emergency. Now, what causes hypercalcemia? Now, if you are faced by a patient with hypercalcemia, whether as an emergency or just mild hypercalcemia in asymptomatic or mild asymptomatic patient, the first important step is to establish whether this hypercalcemia is PTH dependent, is it dependent on parathyroid hormone or independent of parathyroid hormone. In other words, is the parathyroid hormone is the cause of hypercalcemia or not? If the parathyroid hormone is the cause of hypercalcemia, you will find the parathyroid hormone levels high or normal. Because if it's not the cause of hypercalcemia, the high calcium level should suppress the production of parathyroid hormone. If we find parathyroid hormone within the normal level or above the normal level, that means that the primary problem is overproduction of parathyroid hormone. And that occurs in primary hyperparathyroidism, in tertiary hyperparathyroidism, and in other conditions which are uncommon, including familial hypocalciuric hypercalcemia, the multiple endocrine neoplasia syndrome, and lithium therapy. The most important of them are primary and tertiary hyperparathyroidism. The second category, which is independent of parathyroid hormone. If we find parathyroid hormone is low, that means that we are dealing with one of these conditions, either malignancy, which is most of parathyroid hormone independent hypercalcemia. And remember, hypercalcemia and malignancy can occur with or without bone metastasis. You don't have to have bone metastasis to develop hypercalcemia, because most commonly hypercalcemia results from what we call parathyroid hormone-related protein, which is a protein produced by cancer cells, which mimics the action of parathyroid hormone. And this is called humoral hypercalcemia of malignancy. The second cause is vitamin D excess, and there are other causes which are rare, like milk alkali syndrome, which occur in patients taking large amount of antacids. Other endocrinopathies like hyperthyroidism and pheochromocytoma, and steroid diuretics can cause hypercalcemia. So if we face a patient with hypercalcemia, we should ask for parathyroid hormone. If it's normal or high, the most important or the most common cause is primary hyperparathyroidism, sometimes tertiary hyperparathyroidism. If the parathyroid hormone is low, the most common cause is malignancy, sometimes vitamin D excess. The other causes are rare, not common. The features of hypercalcemia include polyuria, polypepsia, because calcium will impair the tubular reabsorption of fluid, gastrointestinal symptoms in form of anorexia, vomiting, constipation, sometimes abdominal pain, and CNS features like confusion, lethargy, depression, and in severe cases, even coma. Now, there is no specific science of hypercalcemia, and the science depends on underlying etiology. The classical sign is said to be the band keratopathy, which is calcification seen on the cornea, which is seen in chronic hypercalcemia, not hypocalcemia. This is a typo error. Chronic hypercalcemia can result in deposition of calcium in cornea. This can be seen by slit lamp examination. It's difficult to see it by the torch or by the eye. But this is not sensitive. It's not seen in all patients. But this is the only sign that you might see on examining patients with hypercalcemia. Investigation, as we have said, we should order parathyroid hormone, because this is what will tell us about the cause of hypercalcemia. We should ask for electrolytes, urea, and creatine, because the most important complication of hypercalcemia is renal impairment. The persistently high serum calcium can impair renal function and can precipitate even acute renal failure. ECG might show shortened QT interval. This is just for information, because that's not diagnostic for hypercalcemia. Affect the treatment. Lastly, the treatment of hypercalcemia, the most important step is volume expansion. We should give fluid, and the aim of the fluid is to correct the dehydration that resulted from the hypercalcemia. Hypercalcemia causes polyuria, polypepsia, and precipitate dehydration in the patient. So we should replete the patient, and in the same time, the fluid that we will give will help excreting the extra load of calcium. This is in most patients the only step needed. Loop diuretics like furosemide, they are used only if the patient has renal or cardiac failure. In the past, we used to give fluid with diuretic. This is not an appropriate therapy now. They are not needed unless the patient is has a volume overload. Calcitonin and bisphosphonate might be added to the fluid replacement if there is no rapid correction of the calcium with the fluid. Calcitonin is usually given subcutaneous to outpatient, but in cases of hypercalcemia emergency, we give it intramuscularly. Calcitonin will decrease the serum calcium within hours, but the problem that its action is short. Bisphosphonate takes some time to decrease serum calcium, but their action is sustained. So if we know For example, if it's a malignancy, we know that malignancy will be a chronic condition with the patient. So when we give a fluid, usually we start bisphosphonate to prevent hypercalcemia from recurring after the acute correction. But the most important step is volume repletion. We might add calcitonin and bisphosphonate of the patient or according to the underlying condition. If the patient has renal or cardiac failure or he's overloaded, we might give diuretics to reduce the overload. So this is the last slide. Thank you for listening, and if you have any question, I will be happy to answer them if I can. Shukran, barakallahu fikum. And there's one question from Dr. Sufyan about the dose of calcium gluconate in cases of hypocalcemia. You will find different protocols, but the protocol we usually use in our hospital, that we take 10 ampoules of 10% calcium gluconate, that is around 100 ml of 10% calcium gluconate. We add it to 400 cc of normal saline or dextrose, preferably normal saline. The bottle of normal saline contains 500 cc. We just take out 100 cc and add instead of them 100 cc of calcium, 10% calcium gluconate. And we will set the rate that this volume is given over 24 hours. You'll find some authority give only 50 cc of calcium gluconate. That's 5 ampoules of 10 cc, 10% calcium gluconate. There are some protocols that give it in 100 cc, give 2 or 3 ampoules in 100 cc, infuse them over 2 or 3 hours, then check serum calcium and then repeat again. But there are different protocols. As I said, the one that we use in our hospital, usually used by most of us, is by giving 100 cc, 10% of calcium gluconate, added to 400 cc normal saline or dextrose saline, and infuse it over 24 hours. Of course, with monitoring of serum calcium every 4 to 6 hours as possible. There is another question. Does it anymore apply that when you take the serum calcium, you should not put the tourniquet? I'm not sure if the newer techniques or assay can overcome this problem, but we still ask for removing the tourniquet before withdrawing the serum calcium. I'm not aware of any modern techniques that can overcome this problem. I saw a patient maybe 2 weeks ago or 3 weeks ago who has hypercalcemia, but when they repeat the serum calcium without tourniquet, it turned out to be normal, more than one time. So I'm not sure. We prefer that we shouldn't put the tourniquet when we withdraw calcium, blood for calcium. Okay, thank you all, and hope to see you soon, inshallah. Thank you, Dr. Sarah, for the arrangement of the lecture, and thank you everybody for listening. Assalamu alaikum.